some of you, and I don't know if you guys have an opportunity to do an assessment of a patient or listen to a patient yet or not. That's something that will happen in time. But again, with assessment, 4 primary parts of the assessment. 4. Inspection, which, long story short, is just the visual portion. Palpitation, kind of hands-on the patient for feeling for various things. Percussion, which is kind of tapping on the patient, and we'll talk about that. And then auscultation. I forget what that part's about, but we'll eventually get there. Those are really the 4 primary parts of the patient assessment. Some of them take longer than others to perform, of course, and some of the different things can mean different things depending on what we're looking at. I will say this, and I may say it again later, the ideal physical examination is performed in a quiet, well-lit place, kind of separate from other patients or other people. Now that's the ideal, depending where we work and the environment we work in. Sometimes things are not so ideal. You know, if it's a code situation, there's a bunch of people in the room, there's lots of activity, there's lots of noises, lots of potential distractions. That is not an ideal situation, but obviously that's an emergent situation that things need to happen pretty quickly. In an ER, sometimes things can get really hectic and crazy, and again, might not necessarily be a quiet area. When I say well lit, because there's things we have to be able to see. And how many people work night shift or probably will work night shift? When you're interacting with the patient, is it always a well lit environment? No. We want to be mindful of the patient, and trust me, there's plenty of health, and you guys know this, some of you know this, there's healthcare practitioners that even work night shift at 2 a.m. when they walk into a patient's room, they flip on the bright overhead lights, even for a patient who is asleep. You know, I'm a little kinder than that. I will turn maybe the bathroom light on with the door open. Sometimes there's maybe a small light like this in the corner, a little away from the patient. You know, maybe I'll turn one of those lights on, but not necessarily the bright overhead light unless there's an absolute need for that. So take that well-lit example with a grain of salt, depending on what we're doing. Like I said, if it's night shift and I'm coming in there and I turn on that little light over there or the bathroom light and have the door open and I realize, oh my God, the patient's not breathing, there's no heartbeat. Okay, then the bright lights come on, then all hell breaks loose, so to speak. All right, so first part here about is inspection, the visual stuff, looking. And the visual stuff can tell us a lot about the patient before we even have to actually touch the patient. So, head and face, examine their facial expression. You know, very quickly we can determine if someone's in a great deal of pain. I noticed that on test days, seeing in your face that you're in a great deal of pain on those days. Depending on the topic, of course. A patient's alertness, their mood, their general character, their mental capacity. What if I'm trying to give patients instruction to do something themselves? Because there's therapies that we do, but we can turn around and teach the patient how to do that in the interim when we're not in the room. You know, if I can determine the patient's really not with it at all, then obviously I'm not going to be instructing them on how to do said therapies. Nasal flaring can be seen in patients with increased work of breathing. You tend to see that more in the neonatal or pediatric population world, more so than an adult. Cyanosis, which I know we've said before, bluish discoloration of the skin. Again, especially if I'm looking at the patient and I notice their lips and oral mucosa. You can have them open their mouth, stick out their tongue. If that is blue, that is cyanosis, but it's a very strong indication that they are having something wrong with their ability to oxygenate when their mucous tongue, lips, mucous membranes are blue. Pursed lip breathing, which I think we talked about at some point before. There's so many things I know we may have alluded to or mentioned here or there, so I hate to bore you guys with repeating myself, but pursed lip breathing, where they exhale through pursed lips, especially those patients with obstructive lung diseases. It helps keep COPD, thank you, COPD again. It keeps the airways stented open. If they didn't, their distal airways would collapse, trapping air. So they learn really on their own. I could teach them this, but they figure it out on their own, that they seem to breathe easier and get the breath out better if they exhale through pursed lips, like they're blowing out birthday candles. Diaphoresis, the term for profuse sweating. Obviously, if you walk into a room, patient's just lying in bed and they're diaphoretic, profusely sweating, something's wrong, something's going on. Now you make me, and I always use the stair analogy, you make me run up those stairs a couple times, you want to see John being diaphoretic, there you go. Make me go run up those steps back and forth. The eyes, looking at the eyes, and all of this is going to be related to something neurological, perhaps. Something going on with the brain. So, pupillary reflexes. Everybody's seen it done before. You know, somebody shine a light in your eyeballs, and what are they looking for? They're seeing if your pupils constrict or dilate. If I turn the lights off in the room, turn the projector off, and it gets dark in here, our eyes will dilate. Once I turn the bright lights on, that's why we all kind of shudder, it's because our eyes then become constricted, but that's a normal neurological response. In a patient's chart, you may see the abbreviation PERLA, P-E-R-R-L-A. Stands for pupils equal, round, reactive to light, and accommodation. I want to see all that. If the patient has a good neurological intact state, then they should have those responses. Just some terms here: mydriasis, abnormal dilation of the pupils. Sometimes you'll hear the term fixed and dilated. Probably not a good response if we have a patient, especially a patient who's in cardiopulmonary arrest that we're resuscitating, when they're looking to see if perhaps there's an indication for brain death. Again, mydriasis. Now, I will say this before we get too far involved. There are certain medications that can cause the same thing. Anybody ever go see the eye doctor and have your pupils dilated? Yes. Happens to me on the most inopportune times, and then I forget what I'm about to go do, and then realize, holy crap, I'm going to be outside, my eyes are dilated, I can't see a thing, because I'm now so sensitive to the light because my pupils are dilated. But remember, it could be medications that could lead to abnormal dilation or constriction of the pupil, so take that with a grain of salt. The term ptosis, drooping of the eyelids. There are certain neurological conditions that we'll be talking about in the future where that could happen. You could have drooping of one or both eyelids. The term myasthenia gravis is one of those neuromuscular diseases we'll get to in the future. Diplopia, blurred or double vision, and nystagmus is kind of an irregular motion of the eyelids where they kind of go back and forth. Looking at the neck. Okay, looking at the neck, probably the first thing here that we'll talk about is jugular venous distension. If we have the patient sitting at a 45-degree angle, we can measure the height of the jugular vein. Now, normally, looking around the room, I don't see anybody with a pronounced jugular vein. Good thing, because if you had right-sided heart failure, you're going to have blood that's starting to back up. You may see some bulging of the jugular veins. They call it jugular venous distension. And so you can estimate jugular venous pressure by having the patient sitting at a 45-degree angle and measuring the distance.
Is that like when someone gets really mad and you can see?
No, different, but I understand what you're saying. I understand what you're saying. Also there at the neck, you can assess for tracheal position. Hopefully our tracheas are all midline. Sometimes you may have to kind of feel, but our trachea should be midline. With certain conditions that affect the lung, it could cause the trachea to deviate to one side or the other. For example, I don't know if I mentioned, I did mention it here. So atelectasis, if the lung collapses, you know what that will do for our currently midline trachea? If I have atelectasis on this side, it will pull the trachea toward itself. If I had a pneumothorax on this side, it would push the trachea away. So those are some clues. PTX, sorry for my abbreviations here. PTX pneumothorax is what I was trying to indicate there. Palpating lymph nodes, looking for lymph node enlargement, lymphadenopathy. Checking carotid pulses for strength, obviously presence of, but also for strength. Again, all that being part of the assessment there at the neck. Lung topography, the geography of the lung itself, I guess. So just point. So when someone's referencing a location on the lung, they may use some of these terms. May sound way too fancy for our discussion sometimes, but again, if there's an MBRC question or a John question that I use some of this topography, want to make sure you know the location. So first one here, Notice the patient is facing you, so this is an anterior view of the patient. They're in front of you, you're looking at them. Right here in the middle, mid-sternal line. On right and left, we have the right mid-clavicular, think about your clavicles, mid-clavicular line versus left mid-clavicular line. On the side, okay, there's our axillary. Mid-axillary here right in the middle. Now in front, that's the anterior axillary line. In the back, there's your posterior axillary line. Now the patient is facing away from us, so we're looking at their back. Mid-spinal line, and then left and right scapular line. Again, just for location purposes. Just what's that?
Remember the test.
Yes. Oh yeah, I'm not talking about the ribs here, but they are counted, so in case you're curious. That's funny. Flashbacks, oh, not the ribs. Anything but. All right, so the suprasternal notch, right here. We can all feel where that indentation is, right above the manubrium of the sternum. All right, can be palpated. The angle of Louis is approximately here, just below that suprasternal notch, right around the sternal angle. The lung fissures, that's what separates the various lobes from each other. The only thing I will add here to the fissures is on the right side, because the right side has how many lobes? 3. Because the right lobe has 3. There is, and again, only seen anteriorly, there is a horizontal fissure separating the right upper and right middle lobe. There is no fissure, on the left. Or there is no horizontal fissure on the left. The carina we've talked about before, that's the split between the right and left main stem bronchi, or the split of the trachea into right and left main stem bronchi, located directly underneath the sternal angle, also referred to as the angle of Louis. The diaphragm, the primary muscle of ventilation, of respiration, separating the abdomen from the thorax. Again, we talked about right side being a little bit, higher or lower than the left? Right side being a little bit higher than the left because of the location of the liver. Chest or thoracic configuration. Barrel chest, which I think we've talked about before because I've mentioned COPD like 65 times since you guys started the program. The barrel shape, what they'll refer to as an increased AP diameter, anterior posterior diameter. If this is supposedly a normal thoracic cage configuration, you can see how barrel shaped his chest is, and it doesn't mean, I always go back to it, doesn't mean that they're overweight. It could be a very thin person and they still have a barrel-shaped chest. Seen with a lot of our obstructive lung disease patients because of air traffic. And so the structure, the shape of the thorax changes. The next two, pectus carinatum, is an outward protrusion of the sternum, where it sticks abnormally outward. Pectus excavatum, where there is an inward depression, again, of the sternum. On the back side, so abnormal shapes here of the spine. Scoliosis, that's the first one, this abnormal deformity of the lateral curvature of the spine. Kyphosis is here, where there's an abnormal curve, kind of hump back, sway back, sometimes they'll call it. And then you have kyphoscoliosis, which is a combination of the two. Again, these abnormal shapes of the thorax, with maybe the exception of the barrel-shaped chest. All of these other shapes could restrict how easy or how smooth the lung can expand, depending on how severe they are. So when we're working with these patients and we're trying to determine what this individual's tidal volume normally is, or if we need to place them on a mechanical ventilator, what tidal volume should I give them? You know, even though they have a certain height and a certain weight, with some of these abnormal shapes, with the exception of barrel shape, some of these abnormal shapes could impact how easy the lung can expand. All right, breathing pattern, I guess that's important. So During normal breathing, we know of course the diaphragm does most of the work. We know if the patient's in distress, shows increased work of breathing, there's going to be those accessory muscles, which the accessory muscles are everything excluding the diaphragm and the gluteus maximus, and you remember that question from the other day. The third bullet point here about approximate IE ratio. Now what the IE ratio represents is not a specific time, so don't confuse it for time, even though it represents the ratio of time. The IDE represents the part we spend in inspiration compared to the part we spend in expiration. Normally, for you and I, we have approximately an IE ratio of 1 to 2. Now that's just part. So depending how long inspiration and expiration took us to perform, one part of that is going to be inspiration, 2 parts of that will be time spent in expiration. Okay, so that's a normal I to E ratio. Our patients who have obstructed lung disease, yes, COPD, could be your asthmatic, could be your emphysema patient. When they breathe, they require longer time to get the breath out. Again, remember, they're obstructive. So it may take them twice as long compared to us to be able to exhale. And so that's why you may see their IE ratios 1 to 3, 1 to 4, 1 to 5 perhaps.
So is the 1 like your inspiration?
Yes.
And then your expiration is the 4 or 3?
That's the I, inspiration, the E,
Okay.
expiration. Yes, absolutely. But don't get hung up on time. It's not 1 second to 2 seconds. Even though it could be right now, it's parts, portions, thank you,
Okay.
portions. 1 portion is spent in inspiration, 2 portions in expiration.
Okay.
And it's hard to sit there and say, go ahead and just breathe and think about it, because then you're thinking about breathing, just same thing as telling the patient you're counting their respiratory rate. It gets all kind of wonky. But if you really think about it, yeah, when I breathe in, about 1 part of that breath cycle is inspiration, with about 2 parts of it exhalation. Now that's important to note, because guess what happens when we have patients on a mechanical ventilator? We can set that ratio to be very specific. We want them to breathe at 1 to 2. Or I know this is a very severe asthmatic who's still wheezing, still has bronchospasm, so I want to give them more time. And I give them a 1 to 4 I to E ratio. All right, retractions, that inward depression of the skin during inspiration. Again, typically that area between the ribs. You may see what they refer to as abdominal paradox, where it almost looks like the chest and abdomen sometimes are going in opposite directions from each other, how they normally should be when we're breathing. This respiratory alternans, this is where we see periods of breathing using only the chest wall muscles, the intercostals, alternating with periods that the diaphragm is working. This is not seen nearly as often as, say, a abdominal paradox, but both indicate significant diaphragmatic fatigue, that the diaphragm, that muscle, is getting extremely weakened, tired, that it can't do the work for every single breath that we take. It has to take a break, if you will, and letting the accessory muscles try to participate and do the normal breathing for the patient. All right, kind of looking, again, still part of inspection here, so a lot of things to look at. So looking more at the core of the patient, the term central cyanosis. Not to be confused with just plain old cyanosis, where we say there's just bluish discoloration of the skin. And I know we talk about looking at the face or the head and seeing maybe the lips or the mucous membranes are cyanotic. Again, by definition, that's cyanosis. But if you notice, not only the lips, mucous membranes are blue, but the core of the patient is blue. When you hear that term, central cyanosis, that means the patient's core is cyanotic. Never a good indication of anything. If the core is cyanotic, more than likely the lips and mucous membranes will also be cyanotic at the same time. Again, lets us know that the patient's having significant oxygenation problems, not being able to get the oxygen into the tissues, not get them into the body that obviously needs it to function. All right, finally, we can move away from inspection for a minute and talk about palpitation. So this is, all right, time to get our hands dirty. We got hands on to the patient here. And there's various things that we can evaluate. So palpitation simply means that act of touching the chest wall, feeling for different things. Some of the things we could look at is fremitus, vocal fremitus. We'll talk about that in a second. Estimating thoracic expansion. Looking at the skin, subcutaneous tissues of the chest. Let's start with the first one here with palpitation, and that's the vibrations. If a patient has fluid, and I think I mentioned this before when we talked about suctioning, I think. Lots of fluid and it's kind of moving in the chest. You put your hands on the patient's chest wall over their lungs, and it's significant, you can feel those vibrations. We'll call that tactile fremitus, because you're feeling that vibration as that mucus kind of moves as the patient's breathing in and out. The term vocal fremitus, these are the sounds we are hearing when the patient speaks. And so we're asking them to say a few words or say a few things. Again, depending if there's air in the chest versus fluid or congestion, the sounds will be obviously different. Palpitation here, talking about thoracic expansion. Easiest way to do it is to do it from behind the patient here. Having your thumbs together, your hands wrapped around their posterior back, and have them breathe. I need you to breathe in deep. If they are symmetrical, if their breathing right and left is symmetrical, my hand should move back and forth equally. If it's only the right side that is moving, then obviously, you know, if I'm here centered, I will notice that very significantly, that only one side is moving more than the other, that it's not symmetrically moving. Some other things, again, just hands on the skin, we could tell if they have perhaps a fever or temperature just by the touch of our hand. Another thing to notice, the term subcutaneous emphysema. Now, this has nothing to do, absolutely zero, don't ask me why they use this word, has absolutely nothing to do with the disease state emphysema, okay? But what subcutaneous emphysema is you can actually feel when you palpate the patient, generally you'll find it more in the neck, upper chest area, you will actually feel air trapped under the skin. You will feel, it almost kind of has a snapping type feel. My best analogy for this, anybody ever have bubble wrap and you can't help it? As a kid, I can't help it as an adult. I still want to pop those damn little bubbles, right? Imagine this is that bubble wrap, but it's really, really fine. Really, really small bubble wraps, and it's underneath the patient's skin. So when you press on their neck, you can almost feel the popping of air. That, again, it represents air that is stuck, air that is trapped, air that's trying to find a place out. That's exactly what it is. It's crepitus. Okay. So where we will see this, or when we will see it, is a patient who has a pneumothorax. What's a pneumothorax again? Air trapped in the pleural space, and it's trying to find a way out. And it's trying to float its way to the top. When we feel subcutaneous emphysema, it's air that's made its way to the surface of the skin, but there's nowhere for it to go. Many times the patient may appear swollen. It could get up into their face, so their face is puffy. Their eyes could be swollen shut because it's air that's just trying to find a place to escape and get out. And I say this in a funny way. Boy, if I could just pop a pin in their skin, we'd have all the air leak out, wouldn't we? It's not as simple as that, but you can actually feel that. And if you ever, in your travels and clinicals, because it's not something you see every day, in your travels and clinicals, whether it's this semester, next semester, the third or fourth semester, you're in the hospital, and maybe it's not even your patient, but somebody says, hey, I've got a patient upstairs who has subQ emphysema. Can I go see it? Can you take me? Can I go take a look? Because it's important to know what it feels like. So once you feel it that first time, you'll never not know what it feels like again. But literally, it's like bubble wrap just under the surface of the skin. Very fine, very small bubble wrap. All right, so this is percussion of the chest. So we're going to be tapping on the chest wall. When we perform it, we're going to perform it systematically, comparing one side of the chest to the other. I'm not going to sit there and do percussion on the right side to turn around and do percussion on the left side. No, whatever area I percuss on the right, I need to percuss that same area on the left. And back and forth, back and forth. Now what percussion simply is if you take one of your hands and hold it flat on your chest, just like I'm doing. You can take your other hand, and that knuckle, I'm going to tap. Now the first row might be able to hear it, right? Right, first row, and everybody on the video. But if you did that to yourself, it's gonna have a hollow sound. Why? Because there's air under here, right? And you really have to kind of thump that knuckle to hear it. So it should sound hollow. The term, where is it? Resonance is that hollow, normal sound of an air-filled lung. Resonance, or sometimes resonant, ending with a T. Okay? That's how it's supposed to sound. Hollow, air-filled. But let's say I have, oh, I don't know, I'll just pick a disease off the top of it. COPD. Or I know I have all this extra trapped air because of the disease, because of the illness, because I can't exhale it all out, so I end up trapping it. Guess what they sound like? They sound even more resonant. The term hyper-resonant or hyperresonance. More air. So it should sound, me and you, should sound resonant. But if I have extra air, like COPD, like emphysema, my patient currently in an asthma attack, I do that, they have trapped air that's trapped, it will sound hyper-resonant.
So just basic, like, regular resonant would be just normal filled lungs?
Normal air-filled lungs. If it's hyper-resonant, there's extra air in there. We just talked about something that causes extra air to be in the chest or into the lung. A pneumothorax.
Yeah.
So if someone has a pneumothorax and you do percussion over the pneumo, guess it's going to sound
More.
very loud, very air-filled. Again, the term hyper-resonance. Now what if I percuss, and I can't percuss over my scapula very well, but you get the point. If I do that over a bone, what would it sound like? It won't be air-filled, it won't sound hollow, it will sound dull or flat. Okay? Now if I have atelectasis, if I have a bad pneumonia, if I have a pleural effusion, something going on where there's not air, it will also sound dull or flat. So that gives us some clues when we're doing that, going resonance, 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 ooh, dull or flat, and I'm still over lung. That's where the atelectasis is, or that's where the pneumonia is, or that's where the pleural effusion is. You can identify where the abnormality is just based on physical patient assessment. Now, we are so spoiled in medicine today, and this includes the physicians, where a lot of them don't even do this anymore. What do they order instead? What do they order? What technology do they use to see what's under here?
An X-ray.
An X-ray. So I get it. I understand. That's probably going to be more accurate than any person doing it. Well, I think, is that pneumonia?
Definitely
Could be a
gives you a
pneumonia
clear-
right there. But we're still going to get a chest X-ray regardless, right?
Definite clear,
I'm sorry?
a definite clear representation of.
Sure. So, but the reason I mention it is the MBRC will not necessarily say the X-ray shows this. They want you to be able to figure out based on an assessment, the term, and again, specifically the terms, hyperresonant, resonant, or dull and flat, what must be happening underneath the skin or in the chest or in the lung. Okay? So dull and flat, you hear that over bone, but dull or flat, if it's over a lung field, that could indicate atelectasis, pleural effusion, pneumonia, something along those lines. Something that you know there's not extra air in. Everybody okay with percussion? Sometimes folks, we talk about it and then they forget when the test rolls around or a test later rolls around, they forget. It's something so very simple, but something that I know you don't get to see done
Oh, it could still happen.
very often, right? But again, the reason I'm emphasizing it is I know the MBRC likes to throw that in their descriptors and question. And so, I'm gonna do it too. All right, auscultation of the lungs. So now we're listening to the chest. So, anybody got to listen to a patient? You got to listen to a patient? Not yet. Some, again, depending on what your job is or what you've done previously, but there will be times, so make sure you do always have your stethoscope with you in clinicals when you get that opportunity, because we could sit here and listen to each other all day long, and after the end of the day we go, yep, I heard clear breath sounds, because we're all assuming we'll have normal breath sounds. But we want to hear the abnormal stuff, right? Well, guess where the abnormal stuff can be found? In the hospital. So it's just a matter of finding that right patient, that right situation so you can hear. And the more opportunities, especially as a student, you can hear, the better you're going to become at auscultation. Again, it takes practice. I wish I could say, oh, we'll go to this website or that website, you'll hear it, Nothing is the same as a real patient, because sometimes the real patients could have multiple breath sounds. When we break it down by individual names of the breath sounds, it appears that, well, if it's not clear, then it's going to have to be a wheeze, or if it's not a wheeze, it has to be a crackle, or if it's not a crackle, it has to be rung. Again, because patients could have multiple, but the more opportunities you get to listen, the better you're going to be. All right, so the stethoscope, there is, again, depending on the brand, depending on the style, there are different styles, different manufacturers that make them, and everyone has their niches and their specialties to themselves. But the basic fundamental stethoscope is going to have a diaphragm on one side. That's the larger end. That's the end we listen to breath sounds with. On the other end is the bell. That's the side to listen for heart sounds. Now, depending on your stethoscope, you may have to do some things to switch back and forth between hearing from the diaphragm or hearing from the bell. So again, diaphragm for lung sounds, the bell for heart sounds. And I say, please wear your stethoscope correctly. Go ahead.
It probably doesn't apply, but
It's okay.
So is the bell for louder noises and the
Lower
diaphragm
pitched.
lower? Okay, so
Lower pitched.
lower is bell, higher is
Is the lung.
okay.
Yeah. So again, I say, please wear your stethoscope correctly. Everybody have a stethoscope? Okay. So I should have said, bring your scope in today. Well, I'm sorry.
I said, I was just gonna write it
Yeah. All right. Another name to add to the list. All right. So when you get home, oh, gotcha. Okay. So I'm not going to put you on the spot, Marlon. But when you get home and you get your stethoscope in front of you, put it on like you would have put it on before we had this class today. Okay. Put it on the way you think you should put it on. Then compare to what we're just about to say. When you put your stethoscope on, how are your earpieces? What direction are they pointing when you put them in your ear? Are they pointing this way or are they pointing that way? Of course, I brought my own stethoscope. So, everybody see this? Do I put it on like this or do I put it on like that? Make sure they're moving this direction, not this direction. You may be surprised if you've been wearing them wrong, that suddenly you can hear a whole lot better. Okay? It's so obvious in a clinical setting where we're working with other RTs, nurses, physicians, other people in allied health, individuals who are students who are still new and learning, and you see somebody put their stethoscope on backwards. I'm not going to embarrass anybody there, but I know it's this way. But people will, add it to the list. People will sometimes wear them this direction. That's not the right way. Before I get to that, another thing about the stethoscope itself. Now let me bounce back to this picture so it's easier to see. Depending on the style, the brand of stethoscope you have, you may have to do some things to switch so you can hear from this side, to switch so you can hear from this end. So for example, this one, it has both the diaphragm end and the bell end, but I can turn and rotate this. And it's gonna open one side or the other. Now this one, you can't really see which side is open. But I promise you, you put this on your ear and you turn it to one side and gently tap, okay? And then, oh, there it is, now I'm hearing it, I'm on this side, okay? Gently tap, because these things are very, very loud. This one you can't see, I mean, you can see me turn it, but and I have no idea just visually looking at it, which side is open, the bell or diaphragm. This particular one, I can actually see a hole here in the bell, and it looks closed to me. If I turn it, okay, there it is. Now it's open. Now I can see all the way through. If I turn it, okay, now it's closed. If it's closed, I'm listening through the diaphragm. If it's open, now I'm listening through the bell. Why are they such different sizes? Pediatrics.
I'm sorry, explain the first one again, just that, because
It's a stethoscope. You guys are just like me. At the end of the day, I get punchy too. All right, so this one.
But like, did it turn also again?
Yes.
Okay.
Except there's nothing I can see
I was
with
about
this
to say, like,
particular model. Like I said, there are probably 100 different models out there, so they can all look different. This one again, I turn. I can actually see whether that's open or closed. And again, if you're unsure, I didn't bring my glasses today, I'm not sure if that's open or closed, you could do the same thing. You could gently tap on either side and be able to hear it if you're wearing the stethoscope. All right, so when you listen, when it's time to auscultate, when you listen, I don't care which direction you go. Up and down, up to down to up, whatever. But what you need to make sure you do is listen to all lung fields and do it systematically, comparing one side to the other. One side to the other, one side to the other. Anteriorly, posteriorly, and don't forget lateral. You hear a lot of good breath sounds if you can listen laterally to a patient. Again, in the ideal situation, having the patient sit up, lean a little bit forward so you can get behind them, you can listen. Again, that's an ideal situation. Now, do you think there's times the patient can't sit up very well and we're in no position to raise or lift the patient? Of course. So we have to modify. We have to modify that. But I still have the anterior side I can listen to, and again, don't forget the lateral side. A lot of times people forget about the lateral side. You can hear a lot of good sounds. Again, comparing one side to the other. One side to the other.
Roll over, Grandma.
And make sure at least one full ventilatory cycle, meaning you hear inspiration and expiration. Don't just, okay. No, you can't listen clear enough that fast. So you listen to one breath cycle, okay, other side. And don't be afraid, tell them, okay, take some deep breaths for me. This is not normal tidal volume breathing. You want to hear what it sounds like. If they start breathing shallow, guess what they're going to sound? They're going to sound diminished or almost absent. They're breathing exceptionally shallow. So encourage them, do some deep breaths. It's not for very long. It doesn't take me long to sit there and listen to their auscultative chest. All right, breath sounds. Okay, talking about breath sounds. So tracheal breath sounds, again, heard over the trachea. Loud, high-pitched. Equal time to hear inspiration and expiration. That sound, the length of that sound will be the same, inspiration as well as expiration. Normal vesicular breath sounds generally are softer, lower in pitch. You tend to hear more inspiration and very little expiration. Okay, just normal vesicular breath sounds. And those normal breath sounds, again, this is anterior, everything that's dark pink here is where you would hear vesicular breath sounds. Here, posteriorly, here's the area you would hear normal vesicular breath sounds. Now let me see if this works. I should have tested it before class, but I knew more than half you guys are already in here, so I'm going for the surprise, because if it didn't work, I wouldn't do it. I would still do the same thing anyway. So let's see how this sounds. That's your normal vesicular breath sound. You can hear it a little longer. You can hear inspiration than expiration. Oops. Alright. Adventitious breath sounds. Adventitious is just a fancy word for abnormal breath sounds, but I don't know what the hell it is. Right? It's adventitious. It's abnormal. Okay? So I'm not going to document and say, oh, you're done. I didn't press the button. Okay, so notice I did give you these sounds. So adventitious is just a generic term for an abnormal breath sound, but as far as specifics, it doesn't tell me the specifics. This bronchial breath sound is the first one. Louder version of a normal breath sound, but it has equal time that you can hear inspiration and expiration. This one's not the best recording because it sounds very echoey to me. But you get the general gist. Again, the best way to do this is to listen to your patient. Diminished breath sounds. Softer version of a normal breath sound, quieter. It could be that just simply the patient is breathing shallow. So I say encourage them to take some deep breaths, but if, hey, I'm giving you everything I got, buddy, okay, well then maybe they just can't move a whole lot of air. Maybe they do have significant diaphragmatic weakness. Could be from airway obstruction, could even be from hyperinflated lungs, like our, those people, I'm not saying it, if you had a nickel for every time I said the initial COPD, you'd be pretty rich by now. But the hyperinflated lungs, because they're not able to move a whole lot of air, they could sound diminished. Absent breath sounds, I think that's a dead giveaway. You're really hearing nothing. Really hearing nothing. There's really no air movement. Crackles. So this is the movement of excessive secretions or fluid, perhaps, in the airways. Described textbook-wise, discontinuous abnormal lung sound heard most often during inspiration. Now it could be something like this. We have a patient with atelectasis. It's really not secretions, atelectasis. But when they take some deep breaths, guess what happens with alveoli? They pop open, and that's the crackling sound we're hearing. So in that example, it's not really because of fluid. It's just the sound of the alveoli kind of popping open. We tend to hear that more later during the inspiratory period, where you're hearing some crackles. Could also be from fluid, don't get me wrong. If there's fluid down here in the alveoli, maybe the patient has pulmonary edema. Okay, yeah, we could hear some crackles with that patient too. Now the term rhonchi, rhonchi is a term that you will hear used. Again, rhonchi describes fluid. My best way to kind of classify or describe rhonchi to you is it's fluid, but in the larger airways. If I was to take my water here and pour it down into my lungs, and you suddenly start listening to me, how you would expect that to sound like. Fluid in the larger airways. Now, what would I do if I spilled water down into my lungs? I'd probably start coughing, and I would probably start trying to clear that stuff from my lungs, because my lungs are healthy, right? My diaphragm is strong. If I cough and I clear those secretions, and now you listen and you go, he's cleared. That's the textbook definition of what rhonchi is. Can clear with effective coughing, but what if my patient can't effectively cough? How about when we suction and we clear it, and now they sound clear? Okay, again, that's the definition of rhonchi. Whereas crackles is much deeper, much further down into the lungs. I can't suction out fluid from a crackle, but I can if it's fluid with rhonchi. Oh, let me play my sound here for crackles. I don't have a good one for rhonchi. Sure.
So the late inspiratory crackles is the alveoli popping open?
Yes. So here's
Is that like when we watched the little thing with the mouse lungs?
I don't remember hearing any.
Or not the crackling, but like when it's
Oh, when it's kind of popping open.
Yeah.
Sure. That's a possibility that we could hear a crackle during that period of time when it's opening. So let's see if I can get this crackles to work right. This one you have to really listen for. It's playing, but it doesn't. It's very quiet. maybe when you get home later, you can play it on your speaker, or again, don't blow out your eardrums, please. You could put your stethoscope on and listen to your speaker. Start quiet with the volume. It's the habit of hearing it from here, because you're not going to hear it over a computer or not hear it in the classroom. But I like that one better.
That's like at full volume. though.
Gotcha. Yeah, I thought I turned the volume up here, but okay. All right, wheezes. I think wheezes is probably going to be the easiest one to recognize when we hear it. But vibrations of the chest wall as air passes through at higher velocity, generally because the airway diameter is a lot narrower. And so we're hearing this loud, high-pitched musical whistling sound. Could be from bronchospasm, could be from mucosal edema or airway swelling, mucus, buildup of mucus, or aspiration of maybe a foreign object in the airway that narrows the diameter of the airway. Let's see if this one, I think this one's loud, so get ready for it. During expiration, we're hearing that wheeze. Again, it's air trying to get through this very narrow passage when this is how open it's supposed to be. Nothing. All right, stridor. Stridor, I think, was it yesterday that word came up, and I kind of very generically described it, but rapid airflow through a narrow site. That's very similar to how a wheeze is going to sound, except this is in the upper airway. Upper airway here, where we're hearing that very loud, high-pitched, stridorous sound. It sounds like a wheeze, but it's happening up here. If I hear it out here, then that's a wheeze. But if it's up here, upper airway, and think about what it means. If it's a narrowed airway, oh my gosh. So this part is getting narrowed. Many times you can hear stridor without a stethoscope. You walk in the room and go, that doesn't sound good, because the patient's upper airway is closing. Now, can be seen in patients with croup or epiglottitis. Generally, that's a pediatric patient population, but epiglottitis could happen to an adult, unfortunately. Or due to inflammation from an allergic reaction, or, and I know why we talked about it, because we were talking about extubation the other day, it could be that glottic swelling, that glottic edema, that's possible. Not saying it's going to happen to every single patient, but possible after you extubate a patient. It's going to happen within the first 24 hours, if it's going to happen. If it's going to happen. And I'm not saying it's always going to happen, but if it happens. Can be life-threatening because it means the airway could be closing itself shut. Let me see if I can get this one to play. You can tell the patient who that is. It's a pediatric patient. Let's do it one more time. That's an infant with croup. A pleural friction rub is a creaking or grating sound as the pleural layers are rubbing together. You know, someone with pleurisy could have a pleural friction rub. Of the ones we talked about, it's probably one of the rarest of what we talked about up to this point. So I promise you, next Tuesday, half the class can't come in saying, I heard a pleural friction rub, because it's not that prevalent where you're going to hear them. Sometimes, I don't think I talk about it here at all, but sometimes you may be listening to an adult patient, male, who may have a hairy chest. And if you move your stethoscope, guess what you're hearing? You're hearing that movement, that friction, that movement of your scope against the skin. Or right now over my shirt, if you were to listen, and again, I'm moving ever so slightly here, you would hear that sound. But that's not coming from my lung, it's coming from my shirt.
Excuse me, sir. Can I shake your chest real quick?
These sounds. All right, voice sounds, this is something you're very rarely, if at all, going to see. It kind of goes back to the other one where Doc's probably going to order a chest x-ray and see really what's going on under the chest. But we can ask the patient to repeat the words 1, 2, 3 or 99 as we listen. if their lungs are air filled, when we hear them repeat 1, 2, 3 or 99, 99, it sounds extremely muffled. We can't really make out what they're saying, even though we told them what to say. But if there's fluid, if there's congestion, something that can help to transmit the sound becomes a little bit clearer when we listen to their voice sounds, when we auscultate them. But like I said, very, very rare that you see this performed really anymore. All right, examining the heart. All right, so we can do similar things here with the heart: inspection, palpitation, auscultation. We can listen to the PMI, stands for point of maximal impulse. If you think about the heart, and I know we haven't had a discussion yet of the heart, so I know our knowledge is going to be a little bit limited there, but the right side of the heart pumps blood into the lungs, the pulmonary circulation. The left side of the heart pumps blood to the entire body. So when you think about it, is it the right side or the left side that's going to work harder? The left side obviously is going to work harder. And is it the atrium that's going to do pumping to the whole body, or is it that left ventricle that's going to do that pumping to the whole body? It's the left ventricle. So that chamber, that location of the heart is going to be doing most of the work, because that left ventricle has to pump blood to my brain all the way down to my legs and my feet. Of the chambers, it's the one that has the greatest workload. So if I am able to listen over this location, I can identify where the PMI is, the pulse or point of maximal impulse. It's around the 5th intercostal space, which if I start counting 1, 2, 3, 4, 5, that's where it is located. I know where it is located normally, anatomically, in its position. But if something is happening with the lungs, and we know where the lungs are located in relationship to the heart, but if something's going on to the lungs, maybe it's a pneumothorax on one side, what do you think it's going to do to the heart? It could shift it. And so if the PMI changes location, you know where it's supposed to be, but you don't hear it there, maybe something's going on within the lungs that's causing the heart to be shifted.
Isn't that also called the apex too of the heart?
Apex is located at the bottom of the heart, so technically, but that's not considered the PMI, but the anatomical location. The apex of the heart's down here at the bottom. The base of the heart is up here at the top, which kind of seems opposite. It's opposite from the lungs anyways. But the base is up here, but the apex is down here at the bottom. Right, heart sounds. Again, make sure if we're listening to heart sounds, we're using the right end of our stethoscope. Diaphragm or bell? Bell. To hear those sounds. So the first heart sound that they could describe is an S1. That's from the closure of the mitral and aortic valve. Those are the two valves located between the chambers, between the atrium and the ventricles. They call them atrioventricular valves. That's the first sound. The second sound, the S2, is closure of the pulmonic and aortic valves. They refer to those as the semilunar valves. Those are closed during diastole, allowing the chambers to fill, the ventricles to fill. Sometimes you may hear them talk about the heart sound sounding like a lub-dub. There's your lub, there's your dub. S1, S2. There's potentially two other heart sounds that could be heard, the S3 and S4. You can hear them on kids. Generally, you cannot hear them on adults unless they have some sort of murmur. Again, murmur is just an abnormal sound of abnormal blood flow moving through the heart, moving through the chambers. But S1, S2. S1 and S2, that's that lub-dub sound of the heart. Have you guys got to listen to our auscultation mannequin in the lab? Yeah, we can program that to have any sort of sounds. So that's a good thing when you're practicing to sit there and switch. And it's easy to work with, to sit there and flip-flop between sounds to be able to hear the different sounds. And I like the one we have because you can use your own stethoscope. We have a couple of others, but you have to use their stethoscope, and then you have to program the stethoscope, and it has to be over the right spot. Yeah. The other one, it was cheaper. We could afford it at the time, so we got it. But when we got this other one, like, yeah, I want it because I want you to use your own scope and not have to listen to Because basically the other style, if you didn't have that stethoscope, it wouldn't be able to work. All right, briefly here, looking at the abdomen. Again, if there's problems with the abdomen, just because of the location of the diaphragm, that could impact breathing. So if the patient has distension or tenderness, we would definitely note that when we palpate the abdomen. If there's ascites, fluid in the abdominal cavity, now that might not allow the diaphragm to fully move down, so that would impact the patient's ability to breathe. Obesity, and I know it's not listed here, but pregnancy, I think we talked about that at some other point. That's going to impact a patient's ability to fully move the diaphragm, to take the deepest breath possible. And that could be a problem if somebody needs to take a larger breath, maybe because they're exercising or something like that. You okay with shortness of breath? Okay. I saw that I was clicking the button. Shortness of breath. All right, looking at the extremities, last part here, looking at extremities. Clubbing of the digits. So looking at the patient's tips of their fingers, looking at the angle of the nail in relationship to the finger, can let us identify if a patient has clubbing of the digits. So painless bulbous enlargement of the terminal phalanges. Both of these patients have clubbing. You can see how kind of abnormally dilated they are. If you were to look, if they were to hold their hand up, you would not see a very smooth, like on my finger, a smoothness going across. There would be a significant angle there. The mechanism for it's not completely understood, but we do know it appears in patients with chronic lung diseases. Chronic means what? Over time, long term. And we know it's those chronic lung diseases that lead to chronic hypoxemia. What is hypoxemia again? Low oxygen in the blood. So when you see a patient who has clubbing of the digits, you know whatever they have going on with them is a condition that leads to hypoxemia, but it's been chronic. This is not something that just suddenly happened today or yesterday or last week. This is something that's been going on probably for years. Now, I remember when I was in your seat, when I was a respiratory therapy student, I remember when my instructor talked about clubbing for the very first time. Now, I'm not going to tell you how old I am, but yeah, we didn't have PowerPoint. We had these overhead slide things that, the transparencies. We didn't have slides, transparencies. So, again, she didn't have any cool pictures. It was just basically text on the screen. But one of my classmates, as she's going over clubbing, and we're here taking notes and whatever, one of my classmates who was sitting close to me said, "You mean like this?" He held up his finger. He was my age, early 20s at the time. He was my age. And looked over, and she came, looked at him, and goes, "That's exactly what it looks like." And so everybody from the class got it. We all kind of piled over. "I want to see. Daniel, hold up your hand. I want to see." He had clubbing of his digits. He was my age, early 20s at that time. What chronic lung disease do you think?
Asthma?
Good question. But with asthma, they typically don't develop chronic hypoxemia. His disease was something that he was always going to be hypoxemic with. Who said it? Cystic fibrosis. Cystic fibrosis. And so, since the day, again, a genetic condition, since the day he was born, he had cystic fibrosis. And if you didn't know him, if you didn't know the situation, you probably wouldn't even think about it unless he started telling you some of his symptoms. But he looked just as normal as everybody else in the classroom, with the exception of ends of his fingers looked like this. Again, because he had chronic hypoxemia. He didn't have to wear oxygen, but his oxygen levels compared to the rest of us were more than likely a little bit lower than the rest of the class. Cyanosis, we've talked about that. This is the third different location. We've talked about cyanosis in this chapter, but now talking about extremities, you can see cyanosis of the extremities. So this is not necessarily the same thing as clubbing. Clubbing is that abnormal bulbous shape on the tip of the finger, but digital clubbing, or clubbing of the digits, it's their extremities, their distal extremities that are blue. So maybe it's just the tips of their fingers, tips of their toes, but maybe the rest of them is not. The rest of them is not. Let's look at the mucous membrane. Stick out your mouth, stick out your tongue. No, that looks pink, okay. But your extremities are blue. Again, we call that digital clubbing, or excuse me, digital cyanosis, sorry, too many C's. Digital cyanosis. Pedal edema, I know we talked about, and I don't remember in what purpose it was, but I know we talked about pedal edema, and when you compress on that swollen foot or swollen ankle and it stays pitted, pitting edema sometimes, that +1 to +4 means worsening. It holds that indentation a lot longer, so +4 would be the worst. +1 of the 4 examples would be the least, but still there is edema and still it is pitted. All right, capillary refill. This lets us know if the patient has good peripheral perfusion. When I use the word perfusion, what does that mean? Blood flow. Blood flow. So what I'm assessing is, does the patient get good blood flow to the tip of their fingers? So how I can assess this, and we call it capillary refill, or cap refill for short. Take your index finger, smash it for just a second, release it, and look at your nail. Now, it doesn't work if your nails are painted. Sorry, ladies or gentlemen. But if you depress your nail and release, doesn't it pink up really quickly, like in a matter of seconds? Go ahead, somebody say it. Mine took 7 seconds to pink back up, John. Usually happens. There's usually one in every class. But when you press it, kind of smash the nail, don't make it painful, but you're blocking blood flow. And then it should be kind of blanched or whited out. When you release it, should pink up pretty quickly, again, within 3 seconds. That lets us know that you, the patient, has good peripheral perfusion. Now, what do you think would happen if my blood pressure, instead of being 120/80 right now, was 60/40? Do you think it would pink up really quick? No, no, no. Meaning, again, blood pressure is so low. Body's trying to pump that blood and it's trying to get to the end of my finger. Not so much if my blood pressure is very, very low. Skin temp, again, just hands on the skin, feeling for warmth or coolness. Skin turgor, again, if you sit there on the back of your hand, kind of pinch your skin or pinch your arm. If it stays if the skin stays wrinkled, which mine doesn't hold it for very long, that's an indication for hydration. Again, I sit there and suck down water all day long trying to be good, but lets us know we have good hydration. My patient who is dehydrated, we do that to them, it kind of holds that wrinkled skin for a lot longer. Is that my last slide?
We have to go over to one more.
Oh yeah, go ahead, sure.
I had a question about the clubbing.
Mm-hmm.
If you were to x-ray, what would you see in there? Is it like fluid?
It's just an abnormal growth of the distal terminal phalanges, including fingers and toes. Again, mechanism why it happens, they're not exactly sure. I have my suspicions or theories, but that's all they are, suspicions or theories. If the body's lacking adequate oxygen, blood flow, which in turn leads to inadequate oxygen levels. And I'm thinking about just extremities. The body, if it had to make a choice, the body would rather that oxygen-filled blood go to the important vital parts of my body, could care less whether it reaches my fingers, right? Unfortunately. So my theory is there more capillaries growing in those patients who are chronically hypoxemic? Again, think about more capillaries, more blood flow, perhaps an ability to get more oxygen at that location. It doesn't happen any other place, but that's just my theory. That's my thought. Maybe that's what's causing it, but it's never been scientifically proven. But it is an indication for chronic hypoxemia. I did want to share, in case you're curious, where some of those sounds came from. I did borrow them from these websites. I've left them in the PowerPoint so you guys can listen to them at your leisure. Those are the ones I thought were the best. They had others, some of the other ones, take it and leave it for some of the others, but I thought those examples I gave were the best. That one, I can't remember if it was a tracheal or bronchial sound. That sounds very echoey. Yeah, that one I didn't like so much, but I wanted to put something on there for that particular one. But you're more than welcome to peruse and look. But my questions for you guys before I let you guys run. First question is, what's the term used to describe when a patient's trunk or oral mucosa is bluish in color? Is that central cyanosis, acrocyanosis, peripheral cyanosis, or is it tactile fremitus? Final answer? A is the correct answer.
And the B one is the one around the mouth.
Acrocyanosis is typically in the extremities. You may see that more in your neonatal population where they may use that word. Acrocyanosis, peripheral cyanosis, I kind of use those almost synonymously sometimes. All right, so this one was A. Next question. Which of the following is considered a normal I to E ratio? Is that 2 to 1, 1 to 2, 3 to 1, 4 to 1, or 1 to 4? 1 to 2. 1 part inspiration to 2 parts expiration. Again, don't associate that with 1 second to 2 seconds. But if it took me 3 seconds to inspire and expire, then technically that is 1 second to 2 seconds. So it just deals with time, how much time it took me for inhalation and exhalation together. But it's parts. 1 part inhalation to 2 parts exhalation. All right, next question. What part of the stethoscope is used to listen to high-pitched lung sounds? Is that the diaphragm, bell, binaural, speaker, or earbuds?
The last one.
The last one, yes. You know, speaking of, there is technology with stethoscopes that you can have basically an earbud, and you're putting something on the chest. I would be afraid I would lose it because it's not big and bulky and long and it's going to attach. Or you can put the apparatus on someone's chest and you hear it going through your earbud type device. They even have other stethoscopes that you can actually record breath sound, which are really, really cool. So all kinds of different technologies out there. And I always say this, in case I haven't said it to you guys before, when your loved one, and I know this is just first semester, so I'm not trying to jump all the way to the end, but when it gets to that point and people are starting to say, hey, you're graduating soon, what can I get you? I want to trade my $50 stethoscope for the $200, $250, $300, or that $400 stethoscope with the earbud and the Bluetooth technology, whatever works. Yeah, that's something I always say. That's one thing. You could also say, pay for my board exam or pay for my license for, and I'm with you. Which one's the highest? That's the one I really, really want first, right? I'll take care of the cheapest one, but you take mom, dad, grandma, grandpa, whomever, you take care of that big ticket item and I'll take care of the lower ticket item, if at all possible. I think that was my last question. Yep, it was. Questions? 309. I have a baseball game that starts at 308. Okay, so I'll see you guys in the morning. We'll do the last part of the airway stuff. And then I know I have a new worksheet for the second class. Yay! Don't get all excited. Bye, no.
So,
See you later. Yes. Good.
So you just hold on to it, click, or hold on to it, like right here. Yeah.
You well, that's what I meant, on you.
Okay, that's pretty cool.
I like that because I really before school. I was going to use for note-taking and stuff. Like black and white, it really helps to write on paper, but
Everybody works.
take notes.
Now, your numbers may be better than the seal fee
Whenever I make my notes, though,
but both of you
I'm
guys,
recording.
now when they shut the door, did you feel a little bit? I got you. Yeah, that's cool. The door's not shut. So, yeah, let's do that. Read the maneuver, and then, okay, we can open the door and take a break.
So when I was trying to